welcome to everybody to this afternoon session about acute respiratory distress syndrome. And today we have a free presentation with excellent speakers who will talk from basic science to the role of non-invasive respiratory support up to invasive mechanical ventilation and more rescue therapies like ECMO. So it's my pleasure first to introduce Professor Rocco from University Federal de Rio de Janeiro in Brazil, who will talk about what have we learned from animal models. Patricia, please.
So why is experimental ALI important? It's important to elucidate the mechanism underlying pathogenesis, progression, and resolution of ARDS, as well as to develop therapeutic approaches. Well, how to select an animal model? First is local availability. The cost is a very important parameter to choose and to select an animal model. The public opinion regarding animal research, emotive feelings with dogs or primates compared to rodents. And different species are best suited to different study objectives. For instance, if survival is the study endpoint, rodents provide an ideal option since great numbers are required, not pigs. Mouse models of injury have specific reagents available and can be genetically modified. And if invasive monitoring or multiple blood sampling are required, we may choose large animal models because we will have easier anatomic access and adequate blood volume. And it's important also, Paulo, to have a correlation between the model and the clinical syndrome. The closer this species is to human phylogenetically, the better is the clinical correlation. So, for instance, we may use a primate, but so complex and expensive. In this study, recently published in 2022, we may evaluate the clinical features of human ARDS, the experimental features of small animal models, and the experimental features of large animal models. I will focus on the specific characteristics of small animal models, experimental population genetically homogeneous, ability for genetic manipulation, ready availability of multiple tissue and body fluid samples, including longitudinal analysis, and adequately powered study for precise endpoints is achievable. And for instance, for large animal models, we may have a continuous invasive physiological assessment. However, we have several limitations using animal models. A lack of an animal model which perfectly mimics the key aspects of human disease. And in this case, we are unable to extrapolate all data obtained in animal models to the clinical setting. Differences in the intensity and temporal evolution of the disease between experimental and human studies. Monitoring the animal models is usually shorter than human syndrome. And most animal models do not undergo therapies. It's important to have these therapies, for instance, mechanical ventilation, fluid intake, antibiotics, which may influence the outcomes in humans. Another important point is comorbidity. Comorbidity and risk modifiers, such as alcohol consumption, may affect the ARDS susceptibility. So another question, how to develop an animal model of ALI, which resemble human disease? So in 2011, a workshop supported by American Thoracic Society decided that experimental ALI need to have these 4 different parameters, these 4 different features: histological evidence of tissue injury, alteration of alveolar capillary barrier, inflammatory response, and evidence of physiological dysfunction. But it's important to know that things evolved since then. In the last 10 years, we have more studies related to imaging, related to molecular biology, related to omics. So this group decided to perform another workshop supported by American Thoracic Society with 50 participants with expertise in ALI and ARDS using the same method, the Delphi method, which is composed of a series of electronic surveys and virtual workshop. Here we have a summary of this Delphi method, the first, the second, the third round. And they decide that the histological evidence of tissue injury need to be characterized according to change in alveolar space, alveolar epithelium, vasculature, alveolar septa, and interstitium. Concerning the alteration of alveolar capillary barrier, you have to evaluate endothelial injury or dysfunction, epithelial injury or dysfunction, lung edema, and transfer of plasma or lung constituents across the barrier. And the presence of the inflammatory response need to be characterized according to these three different parameters: soluble mediator profile, inflammatory cellular composition and characteristics and consequences of inflammation, and the physiological dysfunction according to the gas exchange, lung mechanics, vital signs, and other aspects of physiological domain. 82% of these 50, sometimes 49, 48 experts in this area, they characterize that histological evidence of tissue injury needs to show the proteinaceous alveolar fluids and debris in the alveolar space. The second characteristic, 63%, a validated histologic injury score. Concerning the alteration of the alveolar capillary barrier, 90%, they focus on elevated BAL, albumin, IgM, or other large circulating protein. 96% report that if you want to evaluate inflammatory response in your acute lung injury model, you need to have the increase in chemokines and cytokines in bronchoalveolar lavage fluid or lung tissue. And finally, the evidence of physiological dysfunction, 86%, remain with this focus on oxygenation. You have to have arterial blood gas measurement of oxygenation. And 78%, the mechanics. So in short, the recommended definition, the new recommended definition of experimental ALI. So if you want to perform an experimental model of ALI, acute lung injury, you have to have at least one measurement identified as relevant. And this relevant means the top 4 or 5 most relevant measurements that I presented to you. So which are the major current models of ALI? So we have a model of sepsis induced by sickle ligation puncture, endotoxin, bacteria. We have a model after aspiration, paraquat, lake acid, saline lavage, villi, but more recently, we know how important it is to hit models. These 2 hit models indeed reproduces the main features of human ARDS, but we have sometimes technically challenging. For instance, the most commonly used is a model induced by saline lavage and ventilator-induced lung injury. But we also may develop a model using sickle ligation puncture and hemorrhage, LPS, endotoxin, endoleic acid, a circulation puncture plus gut ischemia reperfusion. But all these models that I present to you, they helped us to understand the pathophysiology of ARDS. And this is so important because initially we thought that ARDS is an inflammatory process. And we focus always on inflammation, but we know that we have the damage of the epithelium, the damage of the endothelium, sometimes interstitium with fibrosis. And more recently, we know how important it is and how important to detail the inflammatory process based on these experimental models. The importance of, for instance, of the mitochondria. And it's interesting to know that all pharmacological therapies were based on the pathophysiology of ARDS. And all these drugs that I'm presenting you now, for instance, methylprednisolone, steroids, were based on the fact that the ARDS present an inflammatory process. Or, for instance, simvastatin. But, however, no beneficial effects were observed. Even though we have preclinical data showing beneficial effects, the clinical trials showed no beneficial effects. And the question is, why preclinical models do not accurately predict ARDS clinical trial results in humans? The answer is easy. ARDS is a syndrome, it's not a disease. And when we develop a model of acute lung injury, we develop a specific model with epithelial damage or with endothelial damage. And we have a complex pathophysiology with different risk factors, different etiologies, and how to mix all these heterogeneous factors during a clinical trial. So this difference between the preclinical studies and the clinical trials are mainly according to these differences in the pathophysiology, these differences in risk factors, differences in the etiologies. So the question is, do we need or do we have to give up studying preclinical models? The answer is no. Despite the inherent limitations, animal models will continue to be invaluable in understanding acute lung injury pathophysiology and in developing new therapies. Developing new therapies start with preclinical models. So I'd like to thank these guys, all groups that work with us, and all collaborators and fundings. Thank you very much.
So we want to talk about non-invasive ventilation in ARDS. Is this a myth or reality? My conflicts of interest. So we can start from the end. I mean, these are the guidelines that were published in
European Respiratory Society.
As you can see here, the non-invasive ventilation has a strong recommendation only for patients with hypercapnia and cardiogenic pulmonary edema. While for de novo respiratory failure and pandemic viral illnesses, basically there is not enough evidence to issue a recommendation. What do we know about the non-invasive management of acute hypoxemic respiratory failure? As I told you, literature data are conflicting, which is the reason why no recommendation can be made in the guidelines. We know that there is a relatively high failure rate, around 40%. We know that there are certain factors that are associated with the higher failure rate. And most importantly, we know that if we delay intubation, this is associated with increased patient mortality. I'm just going to show you a couple of examples. This is a paper published almost 20 years ago by Massimo Antonelli. It's, as you can see here, a prospective study performed in 8 ICU in Europe and in the US on almost 3,000 patients with acute hypoxemic respiratory failure. About 354 of them were treated with an IV ventilation. The failure rate was 30%, and the risk factors for an IV failure were age, a higher severity of the respirator of the patient, a diagnosis of ARDS or community-acquired pneumonia, and a PF ratio below 146 after 1 hour of non-invasive ventilation. And this is taken from the same study, and you can see here that in patients who fail non-invasive ventilation, the failure rate is increasing almost linearly for this etiology of the respiratory failure. And you can also see that mortality is certainly increased in patients who fail non-invasive ventilation. This is another paper that gives us a very important message, which is highlighted in red. There is a strong association between NIV failure and mortality, and this means that we have to make every effort to understand which patients are failing non-invasive ventilation, and to probably not to delay intubation in those patients to avoid worsening of the patient outcome. This is just an example in COVID patients. This is our experience. This was a single-day prevalence study that we published together with Giacomo Bellani in the Annals of the ATS. Again, it's a single-day prevalence study, so many flaws in the study design. On that day, almost 1,000 patients were receiving non-invasive respiratory support outside the ICU. Most of them were treated with helmet, and then with face mask CPAP, face mask non-invasive ventilation, or high flow. And the NIV failure rate was similar to what was reported before, so 37%. And you can see here the factors associated with failure, and clearly it's a higher severity of respiratory failure, as demonstrated by a lower PF ratio and higher PEEP and higher FiO2 in patients who failed, but also indicators of higher distress in patients who fail, which is lower PCO2, higher respiratory rate, and higher frequency of use of respiratory muscles, and worsened sensation of dyspnea. And if you look at the Kaplan-Meier curves on the right-hand side, you can see that there is a huge difference in survival between patients who had a PF ratio below or above 150. This is probably the largest study published on the use of non-invasive ventilation in patients with ARDS outside the COVID setting, and it's a secondary analysis of the LungSafe study. You know that the LungSafe study enrolled almost 3,000 patients with ARDS. 15% of them were managed with non-invasive ventilation as first-line therapy. Again, the failure rate was above 40%. Hospital mortality was strongly affected by failure. And in this study, they also performed the propensity score matching of a certain number of patients treated with an IV, and similar patients managed from the beginning with invasive mechanical ventilation. And again, if you look at the Kaplan-Meier curves, you can see the same message that we found in our study on COVID, meaning that patients with PF ratio below 150 were at much higher risk of failure compared with patients that had a higher PF ratio. So, what is the rationale for non-invasive ventilation and acute hypoxemic respiratory failure? Well, clearly we want to avoid all the complications associated with invasive mechanical ventilation. Patients associated with non-invasive ventilation have lower sedation needs. We know, we have seen that if we are able to manage the patient only with non-invasive ventilation, they have an improved outcome. And something which is very important in conditions like the pandemics, it can be performed outside the ICU. Clearly, there are also risks. This is not only COVID-19, but in every patient managed with non-invasive ventilation for acute hypoxemic respiratory failure. The most important of which is that we have less control of the ventilatory pattern of the patient and of the effort of the patient. So the risk of patient self-inflicted lung injury, again, as we saw, there is a high risk of failure and delayed intubation. And in case of COVID-19 or pandemics, viral illnesses, there is the risk of environmental contamination. And this is a very common, very popular slide that just reminds us that ventilator-induced lung injury is in some way should be recalled as ventilation-induced lung injury, because in patients with high respiratory drive and who make huge inspiratory effort, this triggers a vicious circle that leads to the maintenance, worsening, and progression of lung injury due to the extreme inspiratory effort of the patient. And again, this is called patient self-inflicted lung injury. So the most important message is that we must monitor our patient. So I cannot tell you if non-invasive ventilation in ARDS is a myth or a reality. It's probably a reality, particularly in the earlier phases of ARDS. But the most important thing that we have to understand is that since these patients are at high risk of failure, and since patients who fail have a worsened outcome in an increased mortality, what we have to do is to understand which patients are failing in order to avoid a delayed intubation. So what can we do for monitoring these patients? Well, we can monitor the gold standard for monitoring the effort is clearly esophageal pressure. This is just a slide taken from one of the many papers published so far that just shows that patients who fail on invasive ventilation have a much higher effort, as demonstrated by higher swings of esophageal pressure compared to patients who succeed with non-invasive ventilation. So the esophageal pressure is certainly the golden standard for monitoring the effort of the patient, but we all know that it's not so widely diffused. It's technically challenging, especially in patients, in non-intubated patients. So very selected centers widely apply the monitoring of esophageal pressure in non-invasive patients outside the ICU, for example, but it is certainly an exception. But again, it's demonstrated that patients with a higher effort, so patients with higher total lung stress, and which is a co-author of this paper, have an increased risk of failure. There are less, how can I say, less technically complicated ways to understand which patients are sustaining an increased work of breathing. And this is very experimental, very preliminary, but there are reports that show that during high flow or non-invasive ventilation, for example, monitoring the nasal pressure swings, so the swings in the pressure measured at the nares, has a very good correlation with the swings in esophageal pressure. So it looks like from the study that that monitoring nasal pressure swings is very useful to monitor the patient effort. And also on the right-hand side, you can see one of our recent papers just published in Minerva Anesthesiologica that shows that also the inspiratory oscillations of central venous pressure are a good mirror of the effort of the patient. So this is a very comprehensive meta-analysis just published 2 years ago in JAMA by Bruno Ferreiro that compares non-invasive ventilation, non-invasive respiratory support to standard oxygen. And it shows that non-invasive respiratory support is superior to standard oxygen in patients in almost 4,000 patients with acute hypoxemic respiratory failure enrolled in 25 randomized control studies. And then in terms of survival and certainly in terms of intubation rate. And then it also shows here that helmet non-invasive ventilation seems to be superior to face mask non-invasive ventilation and high flow to reduce both survival and intubation. But the authors highlight that these studies have a high risk of bias, mainly due to the lack of binding for intubation. And so we have to use this data with attention and with care. Most of the data of the superiority of helmet non-invasive ventilation versus, for example, face mask are based on this study, which is a study published by Patel in JAMA in 2016, on 83 patients with ARDS managed for face mask needs in NIV and then randomized to continue with the face mask or with the helmet. And you can see there is a striking difference in the intubation rate in favor of the helmet compared to the face mask, without any difference in the interface-related adverse events. Probably one of the reasons why helmet may be superior to face mask NIV is that with the helmet you can apply higher PIP levels for more prolonged period of time. And similar results have been shown by Domenico Grieco and Massimo Antonelli in this famous paper just published in JAMA. This is a paper on COVID-19 on 109 patients with confirmed acute hypoxemic respiratory failure from COVID-19 that compared NIV, helmet NIV versus nasal high flow. And the primary outcome, which was the median number of days free of respiratory support at 28 days, was not different, but they showed a significant difference in some of the important secondary outcomes, in particular in the intubation rate in favor of the helmet compared to nasal high flow. So the last 3 slides of my presentation are these. I have the pleasure to show you the final recommendations of the new guidelines of the European Society of Intensive Care Medicine that I am sharing together with Luigi Camporota and Caroline Calpi. These are not published yet, but have been presented at the ESICM meeting in Paris in October. And there were 3 PICO questions related to the use of non-invasive ventilation. This is the comparison between NIV or CPAP to conventional oxygen to reduce mortality and intubation. You can see here the 4 spots. And the recommendations were that we were unable to make a recommendation for or against the use of non-invasive ventilation CPAP compared to conventional oxygen for the treatment of non-COVID-19 acute hypoxemic respiratory failure, while there is a suggestion in favor of the use of NIV CPAP over conventional oxygen in acute hypoxemic respiratory failure due to COVID-19, because as we have seen, the evidence is very limited. The evidence coming from randomized studies of high quality. The second PICO question was a comparison between helmet to face mask, and again, no recommendation since there is only one trial that directly compared helmet and NIV to CPAP. And the third PICO question, again, no recommendation for the comparison of NIV and CPAP because there is no studies, and so no recommendation could be made. So in conclusion, we can say that, again, non-invasive ventilation is certainly a reality for the treatment of ARDS, especially in the early phases, especially in patients with a baseline PF pressure above 150. But we have to monitor the patients very carefully. We have to avoid delayed intubation, and more evidence is needed to respond to all the relevant clinical questions. So thank you very much for your attention.
Thank you so much for inviting me. It's a great pleasure and honor to share the session with you, with Professor Rocco and Giacomo Grasselli. So I will do my best to cover that in about 15 minutes. So I hope you can hear me okay. Fantastic. So I have no conflict of interest for this talk, but I just want to say that if we think about the idea of ARDS and how we manage ARDS from a ventilatory perspective, you can see there has been an evolution from a more invasive to a more gentle type of ventilation. So the scope of the mechanical ventilation that now is not so much in terms of maintaining oxygenation at all costs, but try to minimize the intensity of mechanical ventilation. So that has got implications. So when we think about personalizing the first thing we think about is how can we personalize tidal volumes? So this is not new, and I want to start with this because often one of the slides that, well, one of the graphs that I'm going to show is not really popular enough. And I think if you look at those two groups, the lung protective one with 6 mils versus the 12 mils per kilo, there's very clear that there is an advantage for the 6 mils per kilo. But what you can see down on the left-hand side, you can see that this advantage between lower tidal volume ventilation and traditional tidal volume ventilation was only seen in patients with lower static compliance. And the difference between the two disappeared in patients with the upper quartile of static compliance. So what we can see right from 22 years ago, that there is an interaction between the tidal volume per mils per kilo and the static compliance of the patient, which in a way relates to the end expiratory lung volume or to the FRC. And we see that even more clearly in some of the clinical trials and some of the modeling, which I'm going to show you, which go one step forward towards personalization. So if you look at this study, this is from the LungSafe investigators, and they have subdivided this cohort in three groups based on their lung compliance, from the very low lung compliance on the left-hand side to high lung compliance on your right-hand side. So what you can see that if you judge protective lung ventilation based just on mils per kilo of ideal body weight of tidal volume, you will see that the one on the right-hand side have a tidal volume of 8.5 mils per kilo of ideal body weight, whereas the one on the left-hand side have a 7.5 mils per kilo of ideal body weight. So if you judged the adequacy of mechanical ventilation just based on tidal volume, you would say that the one on the left are more protected than the one on the right. But clearly, when you look at the driving pressure at the bottom, you can see that the driving pressure required to deliver 8.5 mils per kilo is much smaller, so about 7 centimeters of water compared to 17 on your left-hand side. So I'm just introducing one way of trying to personalize the tidal volume using the driving pressure. And this is quite clearly also shown in this study where all the patients have been participated to the low tidal volume versus high tidal volume trials have been analyzed based on the elastance. You can see when you go from elastance, a low elastance to a high elastance, clearly the effect of low tidal volume and high tidal volume, it gets amplified. And you can see there's very little difference between high and low tidal volume when the elastance is low, so the compliance is high, whereas this is clearly much more marked and dangerous in terms of the effect on the lung and survival if the elastance is high. And this is particularly important in patients, for example, during the COVID-19, particularly in the first wave, when their lung volume might have been higher than patients with similar oxygenation, but from non-COVID-19 ARDS. So we needed something else apart from mils per kilo to demonstrate that the tidal volume were appropriate and adequate for that particular patient based on the gas volume. And this is a more recent paper which basically analyzes a lot of other trials looking at tidal volume. And you can see three things essentially, that when you divide patients based in quintiles of driving pressure on your left-hand side, respiratory rate in the middle, and tidal volume on the right, you can see that the standardized mortality ratio increases with increasing quintile of driving pressure and respiratory rate, but not in tidal volume. And there is this the relative weight of driving pressure and respiratory rate is 4:1. So it seems like you can increase respiratory rate by 4 times to have the same effect on standardized mortality ratio than an increase in 1 unit of driving pressure. So if we move to the other implication for PEEP, this is a really recent, only sort of few weeks ago was published. This is a meta-analysis looking at the association of a network meta-analysis, in fact, looking at the effect of PEEP and recruitment maneuvers on mortality. And what we can see is two things: that clearly a higher PEEP without a lung recruitment maneuver, it favors, so is beneficial compared to the lower PEEP comparison. But a higher PEEP with a prolonged lung recruitment maneuver, this is increases the mortality. But the idea of PEEP being beneficial in these patients rests on one idea: the idea that patients with more severe disease, and these are patients with moderate severe ARDS, have more potentially recruitable lung, and therefore PEEP might be beneficial. But what we have seen in COVID-19 is that this might not be the case in all patients. And you can see on your left-hand side, you can see that there is a good relationship between venous admixture and non-aerated lung tissue fracture. Whereas in the middle, you can see in patients with COVID-19, that relationship disappears. So there is a dissociation between oxygenation and recruitability, and lung recruitability. And this has been clearly demonstrated in some other studies, and very quickly I'm going to show you that there is an alteration in ventilation and perfusion. So much so that there seems to be, if you look here, patients with DAD control, so ARDS non-COVID-19, patients with COVID-19 have got more globally dilated vessels, which are going to perfuse areas of collapse. So in a way, there is much more shunt, functional shunt, for what can be seen in terms of anatomical loss of volume. And you can see there the iodine uptake, which indicates the perfusion, seems to increase in areas of ground glass and consolidation. So the worse the lung, the more they get perfused. And this is quite interesting because you can see some histological data. These are all independent data. Histological on the right-hand side, you've got 3D modeling, and you've got a little cartoon that shows that there is a potential opening of some of the bronchial anastomosis between the bronchial vessels and the pulmonary circulation that goes even above the alveolar level. So essentially there is an increase in intrapulmonary extraalveolar shunt, which is clearly not sensitive to PEEP, is not sensitive necessarily to other maneuvers like recruitment maneuvers. And this is also very interesting because what they've done here, they've given some agitated saline to a patient with COVID-19, injected it, and they have looked at some ultrasound Dopplers of the vessels, of the intracranial vessels. And what you can see, if there is a big shunt between the right side and the left-hand side, so intrapulmonary shunt or intracardiac shunt, you would expect lots of microbubbles. And here seems to be that the number of microbubbles is inversely related to the PF ratio. In other words, patients with worse respiratory failure seems to have a more communication between the right-hand side of the circulation and the left, pointing indirectly towards this bronchial anastomosis or some other communication which are extra-alveolar. So what can we say so far? We can say that obviously there are differences between what we've seen about ARDS and COVID ARDS, but mainly is to do with the fact that PF ratio, it doesn't seem to be all the time proportional to the non-aerated lung tissue. And therefore recruitability is not proportional to the PF, which is important. And here, if you can see at the bottom here, the functional anatomical shunt is the ratio is low in ARDS, is much higher in COVID ARDS, indicating there is hyperperfusion of gasless tissue. So if we think about positioning very quickly, we know one thing, that prone position works for these patients, and patients who respond have got a better outcome. We've also seen one effect, the effect that this response depends on how much atelectasis versus consolidation. So you can see at the top, there is a lot of patients with atelectatic lung tissue, and that atelectatic lung tissue can be recruited or reinflated, changing position. So from supine, if you look at the feet, toes up and toes down, whereas in patients with more consolidated tissue, that might not be the case. And this explains why you can see patients who respond respond early, and their potential of responding in terms of PF ratio is much more marked as soon as as proximate the prone position is to the intubation. And this is the anatomical explanation. You can see here, these are quantitative CT scan data on the first week, second week, or third week of COVID-19, and you can see that consolidated tissue increases over time, which might explain why a late proning might not result in an effect. And then finally, my fourth point is about extracorporeal support. We started this idea that actually minimizing the intensity of mechanical ventilation is the goal, and therefore this is the place for extracorporeal support. But we've learned recently, there was one trial, the REST trial, looking at low flow extracorporeal support in moderate to severe ARDS, which unfortunately has failed to show any difference in mortality. You can see mortality was 41.5% in the treatment group and 39.5% in the control group. But unfortunately, not only that, but ECO2R was resulted in fewer ventilation-free days, more side effect, and intracranial hemorrhage. So the question is, what about full flow ECMO? And full flow ECMO is shown to be very effective in COVID-19, has been about 11% of all the population had received ECMO, and you can see here the outcomes. These are 90 days outcome, about 36% mortality in COVID-19, which is very similar to the 36% mortality in the Eolia trial and in this single patient meta-analysis, which include the CESAR trial. You can see 36, very similar. And what we also found by doing some matching criteria, a patient referred to an ECMO center who did not receive ECMO versus the one who did, that there was a mortality reduction, about 18% of patients who received ECMO. And this was not distributed across all the groups in the same way. But you can see that depending on some characteristics that you can identify through machine learning, we found that the mortality was different depending on the inflammatory status and some other mechanical characteristics. This has been confirmed by an Australian study here in the BMJ. You can see 7.1% reduction in mortality in patients with PF ratio less than 80, particularly in patients who had a driving pressure which was greater than 15. But ECMO is not just about cannulation, it's just managing complex patients. And these are my last two slides, just to say that patients who go to higher volume centers have an almost threefold increase in survival compared to low volume centers. So clearly there is a volume outcome in ECMO centers for these patients. This is an emulated target trial, which shows exactly the same, the difference between high volume centers and low volume centers. And these are the very recent Euro-ELSO data, which were collected across Europe. And you can see the effect of age, obviously vasopressors, but also the time to ECMO, which is very important in terms of outcome. And this final slide here is essentially the outcome of a recent study just published in Lancet Respiratory Medicine by Carol Hodgson in the group, basically showing the trajectory of disability over time in 6 months. And you can see that the survival is very good for VV ECMO, similar to the UK data, about 72% survival. And you can see almost 1 in 3 has a disability, 1 in 3 has a new disability, and you can see the burden of unemployment is 1 in 4. So there are many, many considerations that we need to learn in the future about the use of ECMO and how to improve survivorship. And with that, I would like to thank you for your kind attention.
Thank you so much, Luigi. So we have around 15 minutes for discussion, and I would like to start with Patricia with 2 main questions. The first one is, you mentioned that, but what do you think is the real transferability of experimental studies to the clinical approach? You mentioned that we should anyway continue with experimental studies, but which are the future perspective in your opinion?
Well, Paulo, it depends on your question. So, for instance, if you wanted to better understand what's going on in ARDS induced by abdominal sepsis, for instance, you have to use a specific model, for instance, cecal ligation puncture, because we have a polymicrobial infection. And the point is, you have to have a very good question to choose your model. This is the most important issue. Not to use, for instance, oh, I wanted to use a model of aspiration because I have a good experience. No, please don't do it. Or because it's I read the paper of 2022, and it indeed it's a model of acute lung injury. Yeah. The point is that you need. And then if you want to, for instance, to evaluate the pathophysiology, you may use, for instance, mice with genetically modified mouse. So preclinical studies, you need to have a question. This is the most important point. Not to use all models at the same time. This is my answer.
So your suggestion is to change the paradigm and move from the experimental model to the question to the question first, and then choosing the experimental model. I think is important. The other issue is that you mentioned that, especially also in this last study, in which they tried to suggest the possible main finding for lung injury. Also gas exchange, and oxygenation is mentioned. But we know, and also Luigi showed that in patients, that now we know more and more that sometimes, or we don't know the frequency, but probably more frequently that we believe, oxygenation does not really is not really associated with the amount of injury. What I mean is that if perfusion is different, may affect differently oxygenation. We have just recently a case in which we are doing the DECT, and we had a severe pneumonia, very severe, white, so ground glass like that. Oxygenation was not so bad, so PO2 200, because the areas of that were non-perfused. So that's explaining why the baby lung was perfused more or less, and so we had much better oxygenation, driving pressure 20 with 6 milliliters per kilo. No? Just to say, so what do you think about this? So the role again of oxygenation, even in experimental model, does it matter, or should we change?
Well, the question is for me or for Luigi?
No, for you, for
me. Okay, so
because this is also important, because we are talking. You need the PO2 feel good.
Okay. So this is a very important issue, because sometimes, we don't have significant changes in oxygenation, but we have significant changes in lung compliance. So, for instance, oxygenation is not the main point to characterize a model of lung injury, regardless of small animals or large animals. So we have to have, even though the workshop published that indeed most experts think that oxygenation is the most important point, we observed in several models that we performed in rats or pigs or mice, that oxygenation indeed is not the most important parameter to better understand the histological changes, or even the diffuse alveolar damage that has been discussed a lot, that is diffuse alveolar damage is the most important point to define ARDS, or we have other parameters to define ARDS. So this is the point, Paolo. I believe that lung histology in experimental models is the most important parameter to be evaluated. And oxygenation, and Luigi can answer this question, this question is not the main parameter to be set, to be evaluated at the bedside.
Giacomo, do you have a question?
Yeah. Thanks. I just wanted to add on what Patricia was saying, is that there are two things that we often forget. The first one is that we now, I don't know why, but since a few years ago, oxygenation means PF ratio, but PF ratio has a strong relationship with the FiO2. So the same PF ratio measured with 40% of FiO2 or 100% of FiO2 have completely different meaning. And this we have to clearly bear this in mind. And the second point is we always forget hemodynamics. So the oxygenation is the result, of course, of the lung performance of the lung, but also of hemodynamics of the patient, which is why sometimes we have a dissociation between the effect on mechanics and the effect of PIP, for example, on mechanics and on gas exchange. And that's another very, very important point, that we should always monitor hemodynamics in our patients. I'm not saying that we have to measure cardiac output in any patient, but we need to know what's happening to it happens very, very frequently to me, but I think that also to Luigi, that maybe you are called because there is a patient who is doing very bad with the ARDS, and they ask you for, let's say, ECMO support. Then if you ask them, what is the mixed venous or central venous oxygen saturation? Who knows? That's a very important parameter. Maybe even more important than arterial saturation. So very simple things, but important to remember.
So Giacomo, just moving on also for about your presentation, can you give some recommendation to the audience, or your experience, based on your experience, of course, on which type of non-invasive respiratory support you are more used to do? So I don't know. Are you starting with high flow, then you move to CPAP, and then non-invasive positive, or you prefer otherwise? So which is your clinical experience in hypoxemic respiratory failure?
Yeah. I mean, it's a very important question, and I think that It clearly depends on the patient, but if I have to think of, let's say, the typical hypoxemic patient, I would say that you can try with high flow, which has the advantage to be better tolerated from the patient, so you can apply the support for more prolonged period of time. But clearly, in hypoxemic patients, let's say white lungs, what you need is basically positive pressure. Okay, so from my personal point of view, and you know, Paolo, because I think that we do the same thing. Like in purely hypoxemic patients, the ideal first line support is CPAP, which is and possibly helmet CPAP, or let's say some form of free flow CPAP that grants a stable level of airway pressure. If the patient becomes hypercapnic or has signs of distress, which is not only high PCO2 but also low PCO2. So if we think that the patient needs also muscle unloading, then probably non-invasive ventilation, non-invasive positive pressure ventilation, which can be done with the helmet or with the face mask, maybe alternated with high flow, so with some breaks, is probably a better choice.
And just another question is, which is your favorite type of support outside the ICU, so in the ward?
From our experience, it's the easiest one is high flow. You can apply helmet CPAP and let's say CPAP. I would be more careful about applying bi-level pressure support ventilation outside the ICU, or let's say outside at least a high dependency unit.
Thank you, Giacomo. So Luigi, I see here, I have many questions for you, but there are two questions, I think. One I see on the chat that is fit perfectly for you. What is the role of APRV or in not only as a rescue in prevention ARDS? I would say, what's your experience and your feeling about APRV first? And then the second, the role of assisted ventilation. And I would like to know also afterwards the opinion of Giacomo.
Okay, well, thank you so much for those two questions. If I start with the APRV one, I think there is a definite role. I mean, if we think about the way the injured lung behaves in a viscoelastic manner, and we think about the way our conventional mode of ventilating delivers pressure and volume to the lung that is injured, in a way is almost designed to progressive collapse. It's what J.J. Marini called the shrinking baby lung. You know, over time, the lung becomes smaller and smaller, and that tidal volume becomes less and less protective in a way, unless some other things are done, like prone positioning, or so in a way, the question is whether really or the patient gets better, which one wins first. And so in that sense, APRV might give the opportunity to stabilize that, to stop that shrinking baby lung and improve the aeration of the lung in a much more stable. Because what it does, essentially, it will allow, with longer inspiratory time, a more even distribution through Pendelluft and time recruitment, that area of the lungs that, with an inspiratory time that is very short, they're not be able to be ventilated or certainly aerated. So in that way, I agree with the way the question has been asked about the prevention. In that sense, is the prevention of that particular cycle of a shrinking baby lung. The second one, assisted, is a bit more complicated because in a way it goes back to what Giacomo was saying earlier on, the same principles of monitoring that apply to the non-invasive ventilation will apply to the assisted ventilation in intubated or tracheostomized patients. So the question is always whether what we give in terms of the unloading or is proportional to that effort. And in the end, that is about the monitoring and some of the more advanced proportional support modalities of ventilation. But that's what I was going to say with the time available, because I think we could do another day on that and probably longer. But I'd like to stop here because Giacomo, I'm sure, has got something more intelligent to say than I have.
No, unfortunately not. The only thing is that during assisted ventilation, you have, again, less control of the patient's breathing pattern. You probably have to accept different targets of gas exchange. Like, for example, you cannot probably accept, let's say, permissive hypercapnia during assisted ventilation if pH is low. And you cannot probably accept also permissive hypoxemia during assisted ventilation, because this affects very much the respiratory drive of the patient and then the effort of the patient. And so the idea is that we all know that assisted ventilation is good, because we will know the advantages of assisted ventilation, but in patients with ARDS, with white lungs, sometimes it's very, very difficult to control the respiratory drive, even with ECMO, even with very high level of CO2 removal by the extracorporeal circuit, you still see patients that are struggling to breathe. And so those patients are not good candidates for assisted ventilation. But again, the most important thing is that you monitor what you do and then you measure. We can measure what we do. And this is the most important, I would say, clinical suggestion I would like to do.
Thank you very much. I think we are just perfectly in time to end this session, where we had a very lovely discussion about different issues related to the new frontiers of experimental settings to better study pathophysiology of ARDS, and we know that we have to understand even more in the next future in order to better personalize the treatment, and we got some insights from clinical point of view, from non-invasive respiratory support to more invasive support in this difficult type of patients. So I really thank all the speakers, and I think we can close this session.
Thank you.
Thank you.
Bye-bye.